Good morning, Mohan sir, and Lakshmi Rani madam. Good morning.
Good morning. స్టార్ట్ చేయమనండి డేవిడ్ తొందరగా సీను.
డేవిడ్ సార్ ఉన్నారా?
హలో
గుడ్ మార్నింగ్. వినపడుతుంది. గుడ్ మార్నింగ్.
వేరే స్పీకర్ అన్న. హలో మణిప్రసాద్. వేరే డాక్టర్ మణిప్రసాద్.
ఒక్క నిమిషం నేను ఫోన్ చేస్తాను.
Hello,
Good morning, everyone. Yeah, sir. Good morning, sir.
Maniprasad. Are you ready?
Yes, sir.
Yeah, good morning, all of you. Today, in the series of neurocritical care and ICU neuro emergencies and neurological problems, we are continuing from the GBS2 followed by myasthenia gravis, and today Dr. Maniprasad is going to talk on critical illness, polyneuromyopathy and nerve conduction study in brief. I request Dr. Maniprasad to start your presentation.
Thank you, sir. Good morning,
One
everyone.
second. I request Dr. Jekina Baina to introduce Dr. Maniprasad. Anna.
Yeah. Good morning, all. Welcome to webinar. And Dr. Maniprasad is now he is a second year DNB critical care medicine fellow. So my request is here today all the residents actively participate. So when he after the case the presentation is over in first 2 slides, just please actively discuss, the residents actively discuss your thoughts from Hyderabad and Vizag. Yeah, over to Maniprasad.
Thank you, sir. Good morning, everyone. Today I am going to discuss about critical illness polyneuromyopathy. Initially, I want to present a case scenario. A patient of 72-year-old elderly gentleman presented with history of pain abdomen, fever with chills, and arterial serum since 4 days. Coming to his past history, he was a known case of CKD, but never dialyzed. CAD, status post PTCA, type 2 diabetes mellitus. Routinely, he was doing his normal daily activities before admission. Course in the hospital, he was diagnosed as urosepsis with shock, AKA and CKD. In view of poor GCS, he was intubated in the ICU, and for hyperkalemia, he was dialyzed twice. And for the urosepsis, DG stenting was done for right pyelonephritis. He had multiple VT episodes during the ICU stay. He developed ARDS and was put on lung protective ventilation, and neuromuscular blockade agent was used for 48 hours. He was on high vasopressor support in view of shock, which was tapered and stopped during the course of the illness. In view of sepsis, he was started on steroids and meropenem, which was later de-escalated to magnexone. Later in the course of duration in the ICU, after 8 days, he developed weakness of all 4 limbs. So, what will be the differential diagnosis of this patient?
Yeah, here he has used steroids for septic shock, neuromuscular agents, sepsis. So this is the status of the patient. So any resident just can initiate the how do you want, what is the differential diagnosis and how do you want to investigate this patient? for a quadriparesis, not plegia, paresis is there.
You can start with the care hospital students.
ఎవరు
No,
కేర్
please,
హాస్పిటల్ స్టూడెంట్స్
no,
పేరు
please don't waste much time. Quickly, if you don't know, somebody immediately intervene. Yeah, Raghu, Shravya, Anita, please.
Sir, this patient is an elderly patient presented with comorbids of CKD and prolonged diabetes mellitus. So he presented with sepsis with necessity of steroids, neuromuscular blockade, and prolonged ICU course with vasopressor support. With paraplegia, my first differential diagnosis would be critical illness polyneuropathy, and second would be new onset Guillain-Barré disease or syndrome, and transverse myelitis is one possibility, and higher pathology like IC bleed or infarct would be the possibility, but it should happen at the level of brainstem to have quadriplegia.
Okay, any other differentials?
Electrolyte disturbances, sir, hypokalemia, hypokalemia can cause. Hypophosphatemia, hypomagnesemia can also cause this kind of picture, sir. For the investigation, first we have to send for metabolic panel, which includes electrolytes. After that, we have to do MRI spine to rule out transverse myelitis, spinal pathology. And then we have to go with EMG, NCS, nerve conduction studies. Hello. Hello. Hello.
Raghu వినిపిస్తుంది.
Okay. So first electrolytes, next MRI, next we have to do nerve conduction studies. If MRI is normal, then we have to go with nerve conduction studies. Nerve conduction studies will give an idea about
What is the sensorium at that time, Mani? When we have
Sensorium was E4, sir. E4, he was intubated UET and M5 to M6, sir. He was drowsy but arousal.
Okay, he's M6 means he is following commands.
Yes,
E4 and M6. Okay, fine. So now the quadriparesis. Quickly, how we have investigated? Just go ahead.
Yes, sir. Okay, sir.
Srinu,
Hello,
Japan.
Japan.
I want to ask one question.
Yeah, please.
So with previous slide, Mani,
Sir.
Resound ostundi.
Can you show the previous slide? Yeah. In that, I want to ask two questions. One is what neuromuscular blockade you used for 48 hours? You used only for 48 hours only?
Yes, sir. Vicronium, we used Vicronium, sir.
Hello?
Sir, we used Vicronium for 48 hours.
Hello?
So Vicronium was used.
Vicronium, okay. And another thing is dose of steroids and duration.
In view of sepsis and shock, started 50 mg QAD, sir.
Okay. And one more thing is, did you monitor the glycemic levels? Any fluctuation?
Yes, sir. He was hyperglycemic.
Hyperglycemic.
Yes.
It is very bad, or did you control strictly?
We used insulin infusion for that for almost 48 hours.
Okay, good, fine. That's all.
Yes.
Why used Vicronium?
Sir, we use Vicronium only. We don't use Cisatracurium. That is very costly. And we used Vicronium because he is on 100% oxygen and PEEP of 14. And we did not do a prone ventilation because he is on
Dialysis.
he is on in shock.
Cisatracurium on view of money issue or any other issue?
Cisatracurium we are not using it, sir, routinely.
Why Anna? Why? We are using only Cisatracurium.
Oh,
That's why I'm asking.
I think we will start using it.
We are using only cisatracurium in ICU paralysis on ventilator.
Okay.
No recronium.
Mm.
Okay, Anna.
Mm.
Continue.
Yes, sir. So differential diagnosis will be GB syndrome, metabolic neuropathies, toxic neuropathies, neuropathies due to nutritional deficiencies, and critical illness polyneuromyopathy. On examination, his limb power was 2/5 in both upper limbs and 1/5 in both lower limbs. In CSF analysis, it was normal. We had an MRI cervical spine, which was normal. Metabolic panel was normal, and we had an nerve
And the
conduction
brain
studies.
was done. MRI brain screening was done.
Yes, sir. It was normal.
Brain screening and
Cervical
MRI
spine.
C-spine also is normal.
Yes, sir. And NCS showed severe axonal polyneuropathy. Diagnosed as critical illness polyneuromyopathy, and he has undergone tracheostomy for difficulty in
No,
weaning.
myopathy. How will you diagnose the myopathy?
I'll discuss it in later
Okay.
slides. Now, at present, his limb power is 3/5 in both upper limbs and 2/5 in both lower limbs. So,
Srinivas
coming to
ఇంకేమైనా యాడ్ చేసి ఉందా? శ్రీనివాస్ and డేవిడ్ కానీ మోహన్ సార్.
లేదు సార్, గుడ్ టు గో.
Yeah. Okay. Fine.
so coming to the main disease, a framework for diagnosing and classifying intensive care unit acquired weakness. The term ICU acquired weakness designates clinically detected weakness in critically ill patients in whom there is no plausible etiology other than critical illness. Physical examination shows diffuse, flaccid, symmetrical weakness involving all extremities and the diaphragm with relative sparing of the cranial nerves. Coming to the burden of the illness, prevalence of ICU acquired weakness is almost 25 to 45%, and prevalence of critical illness myopathy found to be 70% in sepsis, or if ICU stay was more than 7 days, 100% when sepsis complicated by MODS, 7% after orthotopic liver transplantation, 36% in status asthmaticus and severe acute COPD exacerbations. ICU acquired weakness, frequent and severe complication associated with increased mortality, prolonged weaning and reintubation, increased length of stay in the ICU, and disability. Coming to etiology, exact etiology is uncertain. Multifactorial etiology, critical illness myopathy, high incidence in patients receiving large cumulative doses of steroids and neuromuscular blocking agents, implicating these as risk factors. Usually received more than 10 grams of hydrocortisone over a 1 to 2 week period and neuromuscular blockers for 3 to 5 days. Neither the type of neuromuscular blockade nor corticosteroid are independent risk factors for the development of critical illness myopathy. Risk factors for critical illness polyneuropathy, myopathy, and neuromyopathy. Probable risk factors are severe sepsis or septic shock with gram-negative infections, multi-organ failure, prolonged mechanical ventilation or bed rest, increased duration of SIRS, increased duration of MODS, and hyperglycemia. The possible risk factors will be age. The more the age, the more will be the risk factor. Female gender, severity of illness on admission, hypoalbuminemia, hyperosmolarity, TPN, patient on RRT, high vasopressor support, corticosteroids, neuromuscular blocking agents, and aminonucleic acids. But in this patient, we have used corticosteroids, vasopressors, neuromuscular blocking agents, and RRT. We have started on meropenem, and patient was hyperglycemic and with severe sepsis and shock. Pathophysiology of critical illness polyneuropathy.
Multiple factors are there in this.
Yes, sir.
Okay.
So coming to pathophysiology of critical illness polyneuropathy and myopathy. So acquired channelopathies, pro-inflammatory imbalance, microvascular disruption, metabolic derangements, altered cellular bioenergy and mitochondrial function, and alteration of gene expression. The pathogenesis of critical illness polyneuropathy and myopathy. Microvascular alterations, that is vasodilatation, increased permeability, endoneural edema, hypoxemia, extravasation, cytokine production. Metabolic alterations, hyperglycemia, hormonal imbalance, hypoalbuminemia, amino acid deficiency, activation of proteolytic pathways, electrical alterations, ion channel dysfunction, cell depolarization, cell inexcitability, altered calcium homeostasis, changes in excitation, and bioenergetic failure, antioxidant depletion, ROS increase, mitochondrial dysfunction, and apoptosis. Coming to clinical features of the disease, critical illness, polyneuropathy, myopathy, and neuromyopathy have similar presentations that cannot be reliably differentiated clinically. Present beyond the first week of ICU stay in patients having systemic inflammation, multi-organ failure, or those managed with high cumulative dosage of steroids and neuromuscular blocking agents. The involvement will be more in the lower limbs than the upper limbs. The criteria for diagnosing ICU acute weakness developing after the onset of the illness, critical illness, the weakness being generalized, both proximal and distal muscles, symmetrical, flaccid, and generally sparing the cranial nerves. For example, the facial grimace is intact in the patients. Causes of weakness not related to the underlying critical illness have been excluded, and muscle power assessed by the Medical Research Council, some score of 2 occasions separated by more than 24 hours, or dependence on mechanical ventilation. The earliest sign may be of facial grimacing without limb movement in response to painful stimuli. Extraocular muscle involvement is rare, and if present, search for another etiology, like myasthenia gravis. Muscle wasting is variable and frequently discussed by edema because of the prolonged bedridden state and all, and because of this patient was in fluid overload state. Accurate sensory examination, if possible, and is normal in critical illness myopathy, with predominantly a distal sensory loss of pain, temperature, or vibration sensation in polyneuropathy. Autonomic function is not affected. If affected, search for another etiology, GBS. Deep tendon reflexes usually normal or reduced in pure critical illness myopathy and absent in polyneuropathy. Evaluation and diagnostic criteria for critical illness, polyneuropathy, and myopathy. Medical Research Council grading of 0 to 5. Usually we assess the power of the patient in the limbs. So it's same as complete 0 complete paralysis, 1 score minimal contraction, 2 active movement with gravity eliminated, 3 weak contraction against gravity, 4 active movement against gravity with resistance, 5 is the normal strength. So MRC sum score, the minimum will be 0 and maximum will be 60. Significant weakness, the MRC will be less than 48. In severe weakness, the MRC will be less than 36. So where we will be checking the power will be abduction of the arm 0 to 5, flexion of the forearm, extension of the wrist. And coming to lower limbs, flexion of the leg or hip joint, extension of the knee, and dorsiflexion of the foot. In both the limbs, both the upper limbs and lower limbs, we have to assess and we have to score it. If this criteria will be fulfilling only when the patient is conscious and obeying the commands. If the patient is unconscious and not obeying the commands, we have to go to the nerve conduction studies. The ICU acquired weakness, the 3 terms like critical illness polyneuropathy, critical illness myopathy, and disease atrophy. Critical illness polyneuropathy is a distal axonal sensory motor polyneuropathy affecting limb and respiratory muscles. Coming to nerve conduction studies, usually the nerve action potential in the first figure, normal nerve, which is myelinated nerve, showing normal nerve action potential, normal amplitude with normal conduction velocity. In axonal neuropathy, there will be derangement of the axonal integration. So there will be reduced amplitude, but the myelin fiber is the myelin sheath is intact. So the there will be normal conduction velocity because the conduction velocity is dependent on the myelin sheath. In demyelinating neuropathy, example Guillain-Barré syndrome, there will be demyelination of the myelin sheath. So there will be reduced conduction velocity, but the amplitude will be normal, as shown in the third figure. So interpretation of the NCS. When interpreting NCS data, initial considerations are Is the compound potential normal in size and shape or reduced? Is the conduction velocity normal? Below table outlines key differences between NCS results in axonal loss and demyelinating process. As a simple rule, axonal degeneration leads to a loss of amplitude and demyelination leads to prolonged conduction time. The differences will be in the axonal degeneration and demyelination. Sensory or motor amplitudes in axonal degeneration, it will be small or absent. In demyelination, normal or slightly reduced. Distal latencies normal in axonal degeneration, prolonged in demyelination. Conduction velocities normal or slightly reduced. In demyelination, significantly reduced. And FAO latencies normal or slightly prolonged. In demyelination, significantly prolonged or absent. H reflex latencies normal or slightly prolonged. In demyelination, significantly prolonged or absent. Conduction block or temporal dispersion not present in axonal degeneration, present in demyelination.
What is this one? Our NCS in this patient?
Axonal degeneration.
So it's a we have a small amplitude and
Yes, sir.
amplitude
Normal.
is small.
Yes, sir. Normal conduction velocity.
Velocities are normal conduction velocities,
Yes,
and F wave and H reflexes are all
normal.
Okay. Right.
That's about the NCS. And diagnostic criteria for
So
critical illness.
suppose
Sir.
Yeah, okay. You will anyway tell about the myopathy also.
Yes,
Okay.
sir.
Right.
Diagnostic criteria for critical illness polyneuropathy, CIP. The diagnosis of critical illness polyneuropathy is made with the presence of all of the following. Patient meets the criteria for ICU-acquired weakness. Conduction amplitudes are decreased to only two nerves, and sensory nerve action potential amplitudes are decreased to two nerves.
Money, it is compound muscle action potential.
Sorry, sir. Compound muscle action potential amplitudes are decreased to two nerves, and sensory neural action potential amplitudes are decreased to two nerves. Normal or near normal conduction velocities, the absence of decremental response on repetitive nerve stimulation. So the diagnostic criteria for neuropathy. Clinical manifestations, there will be sensory deficits, distal greater than proximal weakness. Coming to electrophysiology, low amplitude or absent sensory nerve action potentials, that is SNAP, low amplitude motor unit potentials, reduced motor unit recruitment, normal muscle excitability, and direct muscle stimulation. As shown in the figure, the sensory will be absent and there will be low amplitude motor. Coming to critical illness myopathy. Critical illness myopathy is a primary myopathy that is not secondary to muscle denervation with distinctive electrophysiological and morphological findings. The diagnostic criteria will be the patient meets the criteria for ICU-acquired weakness. SNAP amplitudes on nerve conduction studies are more than 80% of the lower limit of normal in more than two nerves. EMG in more than two muscle groups demonstrating short duration, low amplitude muscle potentials with motor unit potentials with early or normal full recruitment with or without fibrillation potentials. The statement I didn't understood. Okay. Direct muscle stimulation demonstrating reduced excitability. Nerve muscle ratio more than 0.5 in more than two muscle groups. Muscle histology consistent with myopathy. Diagnostic criteria. There will be no sensory deficits. Proximal greater than distal weakness. Electrophysiology, there will be retained sensory nerve action potentials, low amplitude motor unit potentials, early motor unit recruitment, absent or reduced muscle excitability. Coming to differentiation between polyneuropathy and myopathy. On physical examination, there will be flaccid quadriparesis in both. There will be respiratory muscle weakness in both. In polyneuropathy, reflexes very hypoactive or abolished. Sensation is reduced. In myopathy, reflexes normal or mildly hypoactive and sensation is normal. Coming to nerve conduction studies, compound muscle action potential, CMAP, amplitude is very reduced in polyneuropathy. In CMAP, is reduced in myopathy. Coming to SNAP, amplitude is reduced in polyneuropathy, which is normal in myopathy. Conduction velocities are normal or slow, and conduction velocities are normal in myopathy. Compound action, muscle action potential duration is normal in polyneuropathy, but CMAP is prolonged in myopathy. EMG, it will show as a neuropathic pattern, and in myopathy, it shows myopathic pattern. On repetitive nerve stimulation, both are normal. Direct muscle stimulation, there will be normal response in polyneuropathy, but in myopathy, it is very reduced. And nerve or muscle biopsy, axonal neuropathy in polyneuropathy, and myosin filament loss will be there in myopathy. And there will be muscle denervation in polyneuropathy, but there will be muscle necrosis in myopathy on biopsy. Critical illness neuromyopathy. It's a combination of both. It is diagnosed when all of the following are met. Patient meets criteria for ICU-acquired weakness. Patient meets criteria for polyneuropathy. Patient meets criteria for myopathy. So there will be overlap of critical illness, polyneuropathy and myopathy. Coming to investigations, first thing to decide whether weakness was present at the onset or developed after a sustained period of illness. In our patient, the weakness started after 8 days of the admission. Before admission, he was doing his normal daily activities, and muscle biopsy, nerve biopsy are both are only indicated if diagnostic uncertainty and are not indicated specifically for the diagnosis of polyneuropathy. Differences between critical illness neuropathy and Guillain-Barré syndrome. Prodromal conditions, sepsis and multi-organ failure in CIP. In GB syndrome, gastrointestinal or respiratory infection. Clinical presentation, onset of the disorder usually after intensive care unit admission, often characterized by fairly symmetrical limb muscle weakness bearing cranial nerves. But in GB syndrome, onset of the disorder usually before intensive care unit admission. Infections precede the onset of progressive weakness and sensory disturbances. In sensory deficits are less prominent in CIP, but in GB syndrome, frequent cranial nerve involvement will be there. In CSF, usually normal in CIP, but there will be albuminocytological dissociation in GB syndrome. Electrophysiology, axonal motor and sensory polyneuropathy. In GB syndrome, demyelinating polyneuropathy or unresponsive nerves, abundant spontaneous activity, axonal motor and sensory polyneuropathy. MRI, there will be no significant findings in CIP, but there will be occasional enhancement of spinal nerve roots in GB syndrome. Biopsy, primarily axonal degeneration of distal peripheral nerves without inflammation, and primarily demyelinating process with inflammation or motor and sensory axonal degeneration or motor axonal degeneration only. Treatment, there will be no specific treatment for critical illness polyneuropathy, usually antiseptic treatment, and in GB syndrome, plasmapheresis IVIG. Outcome, recovery may be spontaneous and variable timings. 50% of patients with full recovery, but in GB syndrome, usually more than 75%, there will be complete recovery. Management, no intervention shown to improve the outcome of ICU-acquired weakness in prospective studies. So aim in all ICU patients should be to prevent the development of ICU-acquired weakness, optimize the rehabilitation for those patients in whom the condition develops. Treatment, actually there will be no treatment for CIP or CIM. These are all experimental: nutritional therapy, antioxidant therapy, hormonal therapy, IVIG, insulin therapy, and physiotherapy. But physiotherapy is more beneficial. Prevention of ICU-acquired weakness. Mainstay is minimization of risk factors. Intensive insulin therapy. Target blood sugar of 80 to 110 mg per dl earlier showed in several studies to reduce the prevalence of CIP or CIM. But NICE sugar study does not support it and supports the use of conventional insulin therapy. That is, the aim of RBS is less than 180 mg per dl in ICU patients. More recently, in a single small study, electrical muscle stimulation to lower limb muscles shown to reduce the prevalence of ICU-acquired weakness. The Cochrane reviews of 2014, moderate quality evidence from two large trials. Intensive insulin therapy reduces critical illness polyneuropathy and myopathy. and high quality evidence that it reduces duration of mechanical ventilation, ICU stay, and 180-day mortality at the expense of the hypoglycemia. There will be hypoglycemic episodes in between if you use intensive insulin therapy. Moderate quality evidence suggests no effect of corticosteroids on critical illness, polyneuropathy, and myopathy, and high quality evidence that steroid do not affect secondary outcomes except for fewer new shock episodes. Moderate quality suggesting a potential benefit of early rehabilitation and CIP or CM, which is accompanied by a shorter duration of mechanical ventilation, but without an effect on ICU stay. Very low quality evidence suggesting no effects of EMS, although data are prone to bias. Coming to the management chart, critically ill patient at risk for intensive care unit, acquired weakness. There will be multi-system organ failure, anticipated prolonged mechanical ventilation. The anticipatory management, that is risk factor modification. Direct evidence for benefit, tight glycemic control can be beneficial, but evidence for harm, limit use unless evidence-based benefit, that is limit use of corticosteroids and neuromuscular blocking agents. Indirect evidence for benefit, sedation sparing protocol, early limb mobilization. Theoretical benefit, careful electrolyte management, that is phosphate and magnesium, optimal nutrition, and ventilatory weaning protocol. Coming to prognosis, ICU acquired weakness, an independent risk factor for increased duration of mechanical ventilation, increased weaning duration, increased duration of ICU stay and length of hospital stay, and increased hospital mortality. Approximately 45% of patients diagnosed with ICU acquired weakness die within their hospital admission, with a further 20% mortality within the first year after ICU discharge. ICU acquired weakness associated with acute severe asthma, there will be lower hospital mortality, surprisingly. Those patients who do survive, almost all patients demonstrate improvement in both electrophysiological and clinical findings over time. Complete functional recovery occurs only in 68% of patients. Persistent severe disability in 28% of patients. No prognostic difference between CIP, CIM, and CIN. However, CIP is identified more frequently on follow-up electrophysiological testing and is associated with a more protracted and less complete recovery than CIM. In future directions, a good understanding of the pathophysiology of CINM is necessary to be able to develop goal-directed interventions, and recent discoveries make this a realistic possibility in the future. Skeletal muscle regeneration is reliant on stem cells, that is satellite stem cell. This is supported by human evidence that shows that decreased satellite cell content impedes muscle growth and results in protracted muscle wasting. Emerging evidence shows that impairment of satellite cells leads to inefficient muscle regeneration, and engrafting mesenchymal stem cells restores metabolic and mitochondrial function of satellite cells, improving muscle strength in a mice model. An experimental ICU ProCan model study that reproduced ICU conditions such as sedation, long-term mechanical ventilation, and muscle unloading showed that mechanical silencing is a dominant factor triggering the preferential loss of myosin and muscle atrophy in a period of within 6 hours to 14 days. In a later study, the same authors attempted to identify gene signatures and molecular pathways that regulate mechanical activation of skeletal muscle affected in the ICU. They found that mechanical silencing triggers genes that regulate mitochondrial dynamics and mitophagy, as well as ubiquitin ligases, FBX031 and SMART, which are all reversed by passive mechanical loading. This may explain the beneficial effects of early mobilization and physical therapy in CINM. CINM continues to be an area of active research and discovery, and it's our hope that we will have better understanding and be able to tailor therapy accordingly in the future. Take-home messages. ICU care acquired weakness is a clinical diagnosis of weakness that is classified into 3 components: CIP, CIM, and CINM. Approximately half of the patients with severe sepsis, multi-organ failure will develop ICU acquired weakness. Investigation is reserved for those where there is diagnostic uncertainty. The management is aimed at minimizing risk factors, glucose control, and optimizing rehabilitation. Thank you.
Thank you,
Mani Prasad. Nice presentation.
Thank you.
In your probable cause of developing critical illness neuropathy regarding sepsis, you mentioned about gram-negative sepsis is more common than gram-positive. Is there any reason for that? Gram-negative sepsis induced polyneuropathy.
No, sir. But in in this patient, there is no sepsis. The blood cultures are negative.
Will you rule out sepsis? Blood culture is negative?
This patient, our patient is a septic patient, no urosepsis, pyelonephritis, no. This patient admitted with.
But the later cultures are negative.
Question atama cheppani. Will you rule out sepsis by negative blood culture?
No, no, sir.
Then you are saying our patient is not septic.
No, I'm not telling it. He is not septic, but cultures are negative. No, we are discussing about gram negative and gram positive.
Culture negative sepsis.
Yes.
No, he actually he presented with UTI. Basically, pyelonephritis. We have done a DJ stenting also. And this patient, we expect gram-negative infection, no? Specifically, E. coli we suspect in this patient.
Urine E. coli was positive. Urine E.
Good.
coli was positive. It is meropenem sensitive for that patient.
Yes.
But after 48 hours, he was off vasopressors. And later, after 3 days, we de-escalated the antibiotic. But after 8 days, he developed the this polyneuropathy.
Yeah, see, sepsis is a contributing factor for this.
Yes, sir.
Okay, that is the E. coli grown and sensitive to meropenem. Yes, I think first day onwards we have put this patient on meropenem.
Yes, sir.
No?
Yes, sir. Yes, sir.
Because why? Meropenem? We can a patient with a UTI can do we directly start on meropenem?
Patient was septic. He was on high organ support.
No.
Mechanical ventilation.
No, all septic patients we start on meropenem.
No, sir.
Then why this patient is started on meropenem? Shock is not an indication, no?
What you are suspecting?
So a patient who has a staph also can have a shock. Strep also you can have a shock. ESBL organisms also can cause shock. So is it meropenem indicated? Any reason?
As factors for MDR organism, sir. He has uncontrolled diabetes and poor life state general condition, and he has nutritional deficiencies and he has admissions prior.
Yes, he has a prior admissions and multiple admissions priorly, and he visits the hospital very frequently.
What is the incidence of ESBL E. coli in Indian scenario? Hello. What is the incidence of ESBL E. coli in urosepsis?
Is it residents ka consultants ka?
Residents ke first.
Sir.
Sir, in ICU, ESBL E. coli is up to 40 to 50%, sir. In community, it is less than 20%.
Less than 20 in community.
See, we have calculated for our antibiogram, almost 40 to 50% is in our community is about ESBL organisms. Okay, because of various reasons, home care and all these things. And in ICU, actually, we are all having an MDR organisms. ESBL ICU acquired infections, we are having an MDR organisms more than almost 60 to 70%. Okay.
Yes.
Okay, sir.
Hello.
Yeah. Sir, Chapman, sir.
Yes, sir. Last time in the discussion was going on at the thought in our conduction study, I thought we'll have a little more discussion. Can you have that graph and can you re-explain Mani Prasad garu?
Yes, sir. So basically, we will be having axonal neuropathy and demyelinating neuropathy. Normal nerve action potential, there will be normal amplitude.
Before that, what you tell is what happens in we see few things like GBS, critical illness neuropathy, myopathy. ఈ మూడిట్లలో వాట్ ఈస్ ద స్ట్రక్చరల్ డిఫరెన్స్ ఇన్ ద నర్వ్ లో ఏ ప్రాబ్లం అవుతుంది, దానికి ఎలా టెస్ట్ చేస్తున్నాం?
అదే సార్, ఇప్పుడు axonal neuropathy అంటే క్రిటికల్ ఇల్నెస్ పాలిన్యూరోపతిలో there will be reduced amplitude because the axons will be damaged. In the conduction velocity will be normal because myelin sheath
న్యూరాన్ లో సో ఈ లెంత్ ఫైబర్ లో యాక్సాన్ ఎక్కడ ఉంటది, మైలిన్ ఎక్కడ ఉంటది, అవి అని చెప్పగలుగుతావా? దాని మధ్యలో కనెక్షన్స్ ఎట్లా ఉంటాయి అనేది.
actually myelin sheath లో there will be saltatory conduction.
ఓకే ఓకే, ఎక్స్ప్లెయిన్ చేసి
చాలు. నర్వ్ స్ట్రక్చర్ వేయడానికి ఇప్పుడు టైం లేదు కదా.
యా ప్లీజ్ గో హెడ్ మనీ ప్లీజ్.
Yes sir. In axonal neuropathy the axons will be damaged, so there will be reduced amplitude but the conduction velocity will be normal. But in demyelinating neuropathy the myelin will be lost, so the conduction velocity will be reduced but there will be normal amplitude because the axon is intact. That's a basic difference.
So the amplitude depends on axon.
Yes sir.
And your velocity
myelin. This is a basic difference. And
wave
and about the F wave latencies, H reflexes latencies, these are late responses. And if sorry,
what is that F wave latencies, H reflex latencies అంటే ఏంది?
అవి లేట్ రెస్పాన్సెస్ సార్ నర్వ్ కండక్షన్ స్టడీస్ లో.
అంటే
సార్ యాక్చువల్లీ దాని గురించి సెపరేట్ క్లాస్ తీసుకోమంటే తీసుకుంటాను సార్ ఇంకో నెక్స్ట్ టైం.
ఓకే,
నెక్స్ట్ టైం విల్ డిస్కస్ అబౌట్ ఓన్లీ నర్వ్ కండక్షన్ స్టడీస్. Next
Yeah,
meeting.
last time that was a little doubtful. I thought that's the reason this class was clear.
Sir, adi
actually yesterday he asked me, you want to tell clear the detail about nerve conduction study, it takes one more class.
Yes sir.
Then I said okay, you briefly tell and you can take next class on that completely on nerve conduction study.
Yeah, thank you David, because I'm not little aware of that. That's why I asked.
In next class I'll explain in details sir. Next class.
Next class one more thing also. See, DNBs you will have maybe they'll put a graph and they'll ask us what is the disease. No doubt in that. And club 2 classes. One is do a nerve conduction study. Briefly about EEG also somebody do, some resident do. Raghu or Shravya.
EMG.
EEG or EMG?
EEG. Okay sir. Raghu Shravya, I think
malla EEG next another class అవుతుంది కదన్నా.
Sir, okay. Fine.
EMG and nerve conduction study, that is better.
Yes.
Yeah, better. Okay. Fine.
Yeah. Right. Any questions from Srinivas?
Dr. Mani, do you have any clinical difference in polyneuropathy and myopathy?
No sir. Actually the sensory loss will be there in polyneuropathy, but it will be intact.
Involvement of the muscle groups.
Yes sir, as I previously explained, distal greater than proximal weakness in neuropathy, but proximal greater than distal weakness in myopathy.
Oh yes.
Why patient took 8 days? The patient, you said escalated antibiotic in within 2 days and degestenting was done.
Yes sir.
Why patient takes long time for recovery? Any reason for that? Hello?
This patient is in ARDS and shock. So
Okay.
extrapulmonary ARDS, this patient. That's reason why she recovered faster.
Right. So what is the present condition of the patient?
Patient is now on tracheostomy sir. Patient GCS is fine. E4, VT, M6. His power also increased. We are doing regular physiotherapy and all.
ICU or step down or in the ward?
Today we are going to shift him to ward sir. He's still in ICU.
Are you
Dr.
doing
Mani, what are
Okay, ask.
Maniprasad, what
Sir.
are the antibiotics which can cause neuropathy and myopathy?
Aminoglycoside, sir. Amikacin.
Inka?
Vancomycin can cause.
You have to tell the list, complete list. You are a DNB. Travia, Raghu, Tripti, Sinju, Mahesh. One can add one more antibiotic.
Sir, fluoroquinolones, aminoglycosides, colistin.
Any more? Commonly used colistin తో పాటు there are some chances with polymyxin also and
So some antifungals also.
Not as a primary. You can deviate slightly this word or this word, that word, like seizures, neuropathy, all those things. Metrozil have these neuropathic effects. And any more? Or any other drugs used in ICU causing neuropathic effects?
Metrozilla.
Metrozil content, sir.
Sir, even anti-tuberculous medicines.
Yes. Isoniazid and
Pyrozinamide.
no. Pyrozinamide and ethambutol.
Do you have a list of drugs causing critical illness neuropathy?
ఇందులో పెట్టేయండి శ్రావ్య, later you put a screenshot, no? List of drugs.
Last class లో ఉన్నట్టుంది.
Okay, sir.
ఉంది sir.
So in this clinical examination also is very important. Transverse myelitis ki, reflexes ki, very important to identify. Clinical examination also is important.
Time ఎంత? Any good 15?
డేవిడ్ వైజాగ్ లో ఉన్నావు, శ్రీనివాస్ అహ్మదాబాద్ లో టైం నువ్వు చూసుకుంటున్నావు.
అన్న ఫ్రీగా ఉన్నాడే అక్కడ.
లేదన్న, బిజీగానే ఉన్నది.
ఏమన్నా వెళ్ళాలి ఇప్పుడు?
లేదు, ఆల్రెడీ కాన్ఫరెన్స్ హాల్లో ఉన్నాను నేను, వర్క్షాప్. సరే కానీ
ఎనీ క్వశ్చన్స్ ఫ్రమ్ సతీష్? కనిపించట్లేదేంటి సతీష్? మోహన్ రావు, రాణి మేడం.
మోహన్ రావు ఐసీలో కాల్ బిజీ వచ్చిందని వెళ్ళాడు.
రాణి మేడం, వరలక్ష్మి. సతీష్ రావట్లేదు ఈ మధ్య. ఓకే,
సార్ అదేదో ప్రీవియస్ క్వశ్చన్స్ ఉన్నట్టున్నాయి కదా ఒకసారి
అది ఆన్సర్ చెప్పలేదు. శ్రీనివాస్ క్వశ్చన్స్ ఆన్సర్ చెప్పలేదు.
చెప్పలేదు
ఏ క్వశ్చన్?
జీబీలోని మ్యాథ్స్లోని ఏవో క్వశ్చన్స్ హోంవర్క్ ఇచ్చాను సార్.
Sir, alginocytological dissociation.
Yeah.
చెప్పమ్మా.
So, when there is an inappropriate increase in protein when compared to the total cells in the CSF, it is called alginocytological dissociation. Partially treated meningitis or Guillain-Barré syndrome, so the first differential diagnosis in the ICU. Other causes would be neurotumors and
కామన్ చెప్పు.
even a subarachnoid hemorrhage, intrathecal chemotherapy, encephalitis.
So subarachnoid hemorrhage, what is the actual finding? We'll see.
Sir, RBCs would be high, sir. So because of TLC would be low, but the protein would be high. Then inflammatory polyneuropathy is one of the causes.
Okay.
And CSVT and other autoimmune conditions.
No, much more common.
Encephalitis, meningitis, and neuroinflammation causes are most common, sir.
That's okay. And partially treated meningitis is common. Okay. Tarvata. SAH can.
Yes, Guillain-Barré syndrome or neuroinflammatory conditions.
What kind of patients you will see raised protein and less cells? Patient is not able to achieve a cell count. He is not able to produce a cell count. What kind of patients?
HIV, sir, or any
immunocompromised
state. Patients on chemotherapy. Patients on chemotherapy.
Immunocompromised patients. You can have alginocytological dissociation.
Yes.
Where questions are what are the criteria for diagnosis of GB syndrome? Sinju, are you there? Sinju is not there. Raghu, Mani Prasad. Hello.
నువ్వు చెప్పు సీను, పర్వాలేదు.
Hello, Srinivas. If they are not responding, you tell because of time concern.
Sir, they will find out and they will post with them.
Then they will, they can find out and later they can tell.
Yes, sir.
Yeah.
Okay.
So another not related to neurology in this case, this patient, he said developed multiple episodes of VT. What is the cause of that VT?
No, Truptri and Savia, both of them put the drugs related and what is going to Sanjeev Petter group lo.
Pettera? Chodam.
Mani.
Sir.
Question adigadu.
Sir, patient is basically hyperkalemic, sir, since admission. That's the indication for dialysis.
Not only hyperkalemic kada.
He has history of coronary artery disease, which was actually there is no history of PTCA, but he was advised for a medical management, and that too 25 years back. Post that he never had a follow up, So I think cardiac issue, coronary artery disease is a cause for recurrent VTs.
Yes, because this patient who is having a long-standing diabetes, hypertensive, and a CKD, these patients, even though there is no history of CAD, also can have a coronary artery diseases. Now, in this patient has a coronary artery diseases on medical management. He is also having severe LV dysfunction, no?
Yes, sir. Moderate. Better.
Undi sir.
Severe ఉన్నట్టుంది ఈయనకి severe LV
It's a
dysfunction.
global hypokinesia or any RWMA?
Global hypokinesis, sir.
What is the ECG findings? ECG normal? Hello?
Sir, ECG is normal only, sir. This could be even stress-related cardiomyopathy.
Stress-related
ECG మరి తెలియదు అంటే నార్మల్ ఇన్ ద సెన్స్ ఇస్ there is no STEMI that we can say.
Yes, sir.
Yes.
The patient is having non-sustained VTs intermittently at the time. This is not due to hyperkalemia or anything. It is post dialysis and this non.
How will you diagnose?
We have even shown to the patient family members also because.
No, how do you say it is septic cardiomyopathy? Is there any evidence for that?
Septic or stress, edana.
Whatever it is. What was the previous cardiac status, echo report?
Sir, he was not following up on with the cardiologist, sir. This history is 25 years back that he has a coronary artery.
We said the patient had coronary artery disease. Now patient is having moderate LV dysfunction with global hypokinesia. So without checking the previous echo or ECG, how can you conclude that patient is in septic or stress cardiomyopathy?
Kaad sir, mundu details aithe వాళ్ళ దగ్గర లేవు sir. 25 years back
coronary artery disease since 25 years might have developed already LV dysfunction due to so many their diabetic issues are there, old age, CAD.
This patient actually, suppose a patient is having septic shock and having a severe or moderate LV dysfunction, and again after you check it, after once the sepsis course is over and the patient now stable ఉంది కదా, ఇప్పుడు good LV function ఉంది అనుకోండి, you can think of septic cardiomyopathy in this patient.
That's why
and one more thing is, even septic cardiomyopathy also, they found that some of the studies says that there is a regional valve motion abnormality is found. So
definitely.
it's very difficult to identify.
There will be a regional valve motion abnormality, particularly anterior valve completely akinetic or hypokinetic in septic or stress cardiomyopathy. It will be recovered. Yeah, that's why Srinivas said it will be recovered once patient is recovered from sepsis.
Yes.
That's why we have to diagnose septic cardiomyopathy. You can initially diagnose, but it will be recovered to normal or near normal.
Yes.
Sarana, any questions from Mani Prasad? Can you tell narrow conduction study and EMG in the next class?
Yes, sir.
And all the residents, my request to all the residents is, this is a forum you have to, even if your answer is correct or wrong, you can answer it. Because
they have to respond.
See, if you respond now, when you go into the real exam, you will automatically respond. Otherwise, మోమాటం ఉంది, వాళ్ళు ఏమనుకుంటారో వీళ్ళు అనుకుంటారో అంటే ఎగ్జామ్ కూడా అదే అవుతుంది.
Yeah, whatever it is, correct or right, you have to respond. They are not responding. We have to call by name. You need not call by name. One group is there.
You have 4 to 5 hospitals and 4 to 5 thought process. You can have a best discussion over here.
Yeah. Once Srinivas gives some questionnaire, you please read for the next class. and all have to respond. Not only single person persist regularly. Hello.
Yes,
Yes,
sir.
sir.
Sorry, Anna. Anna, sir, we will close. Shall we close? Thank you, Mani Prasad, for a nice presentation and nice participation actively in. Sir.
Most of the classes normally is the one side because only you listen, you don't listen. This is the only class we wanted the students to participate and involve more and more. It's not ragging, it's not for just only for
for their benefit.
Yeah, please
Yeah,
let us don't feel anything because we don't feel because we are also like that. Not a problem because you can just, as you said, right or wrong answer, just try to attempt. Thank you.
Yes.